Welcome everybody to the next webinar in the webinar series of Princeton University in the Bendheim Center for Finance on economic implications of the COVID crisis. We're very glad to have Paul Romer with us. Paul Romer is well known for endogenous growth. He's in the economics of ideas. He got the Nobel Prize for it. He did charter cities, so he has also done real implications. So there are many, many things we can learn from him, and we're very glad to have him with us today. Before we start, I would like to do a little bit of advertising for the next speakers coming up and also raise the questions we would like to address in this webinar. So Monday, Olivier Blanchard will talk about the fiscal implications of the crisis. And I should highlight that it will be at 12 o'clock New York time, so 6 o'clock in Europe in the afternoon. And if you want to ask questions, you can always ask questions through the Q&A box of the Zoom software down on your laptop. Then we have Angus Deaton coming up, and Hyun Sung Shin will talk more about the international capital flows. And Tyler Cohen will actually then talk next Friday more on the implication of the liberal society as we go through the crisis. So with this quick advertising, let me just raise a few questions which we hopefully can discuss today. So the first question is how to exit the lockdown. So how can we avoid some flare-ups? Or can we avoid it? Is it too costly to avoid it? And do we need then, when we have flare-ups, subsequent lockdowns? Do we want to avoid it? And if we avoid it, how do we do it? One answer is, of course, testing. But the different types of tests. You can test, whether the infection has occurred or somebody's infectious and contagious. Another test is to test whether somebody's immune. But if somebody's immune, he might still be contagious to the others. So he still might cause externalities on the others. Should we allow them to work because they're immune or not because they might also be contagious to the others? So this has huge implications how we design the opening of the economy. To what extent will we use some smart apps to open up? And then there are also some privacy considerations on that. So Germany has developed some app, for example, where there is some privacy maintained. Do we care about privacy considerations, or is the crisis so severe that we actually have to put privacy at the back burner for the time being? And do we want to open up just to experiment how it works? So we open up to experiment. Do we open up in certain regions only to experiment? And if we open up only in certain regions, which regions will we open up? Do we want to open up only certain sectors? And then the questions are, what are the criteria? Which sectors we open up, which ones are not? Of course, the essential ones, the healthcare sectors, are still open, so we have to open them up anyways. But there might be certain sectors where there's more contagious risk than in others, and some sectors which are more essential. So we can talk about these are interesting questions. So the question is how to design the exit from the lockdown. And then the question is when to do it. And it's also a question of cost and benefit in these terms of human lives. If you lock down the economy, you also create some other costs in terms of health and human lives, not only economic costs. Are these costs growing linearly as we extend the lockdown, or they're growing exponentially? Or what fashion are they growing? There's a recent paper by two co-authors of mine, Sergio Correra and Stefan Luck, as well Emil Werner, former Princeton PhD student, who actually show in the 1918 Spanish flu, regions which open up too early, actually it was pretty economically costly for them in the long run. So it's very important to figure out not only how to end the lockdown, but also when to exit the lockdown. And then there are some long-term questions, and Paul has worked a lot on the economics of ideas and innovations, and that leads to endogenous growth in the whole economy. What long-run implications will the COVID crisis have? It will surely stir some innovations. It will stir some innovations in the telemedicine. We, of course, will try to develop new vaccinations. But finally, we might also be much more aware of the problems of the antimicrobial resistance we have for other diseases, which the society ignored for so long. And then as we use the Zoom software here, we can also see that there's new technology getting a breakthrough, and sometimes you need an extra kick to get a breakthrough to get new innovation going. Then the other questions in the long run, will air travel come back? We know from some volcano erupting in Iceland, air travel was down too, but then it came back significantly again? Will it come back or will it not fully come back? And home delivery, will we still go to supermarkets down the road or will it be all replaced with home delivery? And all of these things might affect the long-run outcome, the long-run economy, in good and in bad. And hopefully we get a little bit of an idea which way this goes, but it's very hard to predict at this moment. And I hope that the poll will shed a lot of light on these questions and also on the dynamics of the crisis and all the different ways we can actually overcome and avoid flare-ups and other phenomena. So Paul, I will pass it on to you. I will stop sharing my slides and you take over. So I should also say, as Paul is changing, you can ask questions in the Q&A. I will recollect these questions and I will ask them as I see them fit. I can probably not cover all the questions, but feel free to ask questions. I wanted, it would be nice to have some interaction with you and with Paul.
Great. So Markus, you can hear me? Okay, good. I'm going to share my screen to just show some images. I want to start by just giving a quick overview of the seriousness of the economic crisis we're facing. A lot of coverage of the, the COVID crisis, but I want to kind of show what we know, what little we know about the economic crisis. I want to talk briefly about something Markus alluded to, which is, what are the possibilities in terms of recovery? But then I want to turn to the, and I'll try to go through those quickly. I want to turn to this discussion about what options do we have for both fighting the pandemic and starting to recover from the crisis. So if I can share my screen here, the first thing I want to do is just make sure everybody has seen this slide. So this is the picture of claims for unemployment. And the obvious point is that the number of claims, which is a sign of the rapidity with which this crisis is unfolding on the economic side, the number of claims this week and the week before are just astonishing. We've gone in 2 weeks from about 3.5% unemployment to nearly 10% unemployment. There's every reason to think that this is going to continue. I think I have to stop share and then share again to show you my next picture. This is I'm trying to share a picture of oil prices.
We saw it briefly.
Okay, yeah. Okay, so you can see it. Good, all right. So the oil price picture is another one we have that you've heard about, but the sharp drop, I think, is just a suspension of trading. But oil prices have declined from something in the 50s to something in the low teens, and this has happened very, very quickly, just in the last month. We've never seen a crisis hit this fast. And the magnitude is, I think, on track now to exceed the magnitude of the crisis during the Great Depression. Reasonable estimates are that we'll get to 30% or more unemployment, which is more than we saw during the depths of the Great Depression. So it's an extraordinarily serious economic event. Now, if I share the next thing. This should show you an image of the crisis in. So are you seeing a slide that shows the financial crisis, 7.5% reduction?
Yes, we see it.
Okay, so this is a way to think about what happened after the financial crisis. And this is about a 7.5%, what looks like kind of fairly permanent reduction in GDP. So the circumstances there may have been unusual. There may be reason to anticipate that we'll go back to trend when we recover from this crisis. But but we should at least be alert to the possibility that that doesn't always happen. If I can go to the next slide, you know, what we're going through right now is this huge reduction. I made these slides a few days ago for another purpose. I think the current estimate here, 137 billion, is way too small. I think it's now more like 350 billion to 400 billion a month in reduced output. That's just how quickly. So I think the current reduction in output is now well beyond 7.5%, more in the range of 10%, and we may be on the way to 20%. So there's a potential cost of, say, $350 billion a month in reduced output. One way to think about what could happen is we could recover to a new lower trend line. There may be some permanent loss relative to trend, and we need to be thoughtful about that. We have some ability to influence whether we have a quick recovery or a delayed recovery. And if we're losing 350 billion a month, if we can recover, say, 250 billion a month of that, then if we can get back to that new trend level a couple of months earlier, that might mean 500 billion in additional output because of the quicker recovery. The last point I wanted to make is that it's possible that the longer we delay in establishing a recovery, the deeper the permanent loss. So the advantage of a quick recovery might be a return to a higher trend level and several months of lost output that we don't have to lose. If you allow for this possibility that we could have a permanently lower trend because they're just activities that don't recover. Think about the restaurant business, or many traditional forms of small businesses. Think about human capital. If we have a permanent loss of output, then the cost of delay is just enormous. So instead of thinking about like $1 trillion of gain from a quicker recovery, we could be looking at 10 times that, an order of magnitude more, because of the present value of the loss associated with a permanently lower level of output. So the point of all of this is just to say that a quicker recovery could be enormously valuable and really worth trillions, not billions. Okay, so that was the first part of what's the economic side. Now, what I want to turn to next is the various strategies that we can use to deal with the managing the epidemic and potentially recovering sooner. Now, there's an equation here I'll talk about in a second, but let me just frame this for you. I do not think the interesting conversation here is about more or less lives lost versus more or less money. That's just not where the interesting conversation is. The conversation needs to be about, given the lives that we want to, or that we would save on the current baseline strategy, is there a way to actually save more lives and have more output, get some economic gains? Is there something just deeply inefficient about what we're doing? And I think the answer is that what we're doing is deeply, deeply, profoundly inefficient. There is a nuance here in the sense that we can't shift today to a more efficient strategy. But I think now it was quite feasible for us to shift within a month or two to a strategy which is just profoundly more efficient than the one we're on. So let me describe to you what that strategy looks like. Then we can talk about how difficult it might or might not be to implement it. What investments do we have to make to be able to implement it? So the first step in this analysis, if you see my distracting pointer, is to start with the notion of R0, the reproduction rate of the virus. I'm going to just use as a round number 2.5. We can adjust that. You'll see it doesn't matter. So if there's one person today who's infected, we're going to have on average 2.5 people who are infected tomorrow. Now, I want to use phi as the fraction of the infected who are in isolation. So imagine you've got 2 people who are infected. If they're both out in circulation, you got 2 today, you're going to have 5 infected tomorrow. 5, but if you have 2 infected and one of those infected is in isolation, then you're only going to have 2.5 tomorrow. So the fraction in isolation directly reduces the reproduction rate. So I'm going to refer to R prime as 1 minus phi times R0, and that is supposed to signify equation 1. So I'll talk about how we could get to a phi of about 0.7. So then we'd be looking at 0.3 times R0, which would mean an R prime, I'm just going to make up prime as the alternative symbol here, of 0.75. With an R that's significantly, reliably below 1, then we can be confident that any new infections will not spread very far. Any new infection that, say, could come in from outside the United States will be damped down. It will die out quickly. Any existing infection in the United States will damp down. And so far, nothing in this calculation matters except the fraction of people who are infected who are in isolation. So you want to think of this as being something that could operate in an environment where you've got a very high prevalence or a very low prevalence, like the one we may have to maintain for months or years to come. So now the question is, what kind of rough calculation could we do about a way to get a certain fraction of the infected into isolation? So here I'm going to use T to signify the fraction of the population that we test each day. We'll come back and talk about what type of test, but don't worry about that for now. I'm going to use L as the symbol for days in isolation. I'm going to use N as the false negative rate for this test. So T times 1 minus N, and if you're I'm going to assume random testing. So if you just randomly test people in the population, T times 1 minus N is the fraction of people who are infectious that enter isolation each day. Okay. Now I'm almost done here. And I already made a mistake in my notation. This should be phi. I changed from phi to F. I apologize for that. My screen will update in a minute, but if this fraction in isolation is the product of T times 1 minus N times L. If you're putting a certain fraction into isolation each day and they stay there for a certain number of days, then the total fraction that's in isolation is just the number of days times the number you put in each day. So the kind of numbers I want to suggest are you test 7% of the population each. So there we go. So we're back to phi. 7% of the population each day. We have a false negative rate on a test of about 30%. So of the people who are actually infectious, you only catch 0.7 of them through the test. I'm going to assume 14 days in isolation. And then if you just do the math, you get to a fraction of the people who are infected that's about 0.7. So comparable to what I described on the first page here. So all, and I'm going to emphasize all because all is a lot, but all we have to do is test people with an existing test, the RT-PCR test, at the rate of about 7% of the population per day, put into isolation the people we test, and then we can be certain to keep R0 well below 1. And remember, this applies no matter what the prevalence is, and we don't know what the prevalence is. So there's some details in this calculation that you can think about. One is that I'm assuming we're actually randomly catching people who are infectious at any time when they're infectious. And that's an assumption which could be off, but we can talk about correcting for that. You know, imagine that people are only infectious for the first 2 days after they're themselves infected. And suppose your test, suppose you never test anybody in the first 2 days. Well, then, you know, you're not going to be quarantining people who are infectious, so that would fail. But if you have this sort of uniform pattern of infection and you're uniformly catching people, this calculation is right. The other thing is I'm assuming right now a kind of a constant fraction of the population who are infectious. If you're in the midst of an outbreak, so this is growing exponentially, my simplification of just multiplying days times the number you're putting in will be inappropriate. So we could model an exponential growth in the number of infectious who are infectious. But I think this situation where there's a stable number of people who are infectious is the right one to use when we're thinking about a situation where we're in lockdown, we've gotten R0 close to 1 or slightly under 1, and then we want to contemplate starting to fold in testing and isolation based on tests. So we could talk about other qualifications in this calculation, but the real issue here is just a question of fact. Could we test 7% of the population each day? This would mean roughly, 20, 22 million people who are tested each day. This is a lot more than we're testing right now. I think right now we can test about 100,000 people a day. So we got to make some investment to scale up our capacity for testing. I started this from the perspective of my experience with technology and growth, thinking there's all kinds of possibilities for rapid technological progress in testing. It's not going to be very hard to scale out testing. That was just a kind of a prior. The other thing, though, that I was thinking about is these nucleic acid tests are basically forms of information technology. You're just like looking for a bunch of things that are almost like bits. They're just kind of, like the elements in the DNA is made out of. So if you're talking about something that involves information technology, we know that the potential for rapid technological progress is very high. This is not like storing energy in a battery. This is not like moving mass, between the continents, where there's just basic physics that limit how efficient you can get this. Information processing is just wide open for rapid improvements. Now, based on a few conversations I've had, I've been astonished at how much room there is to scale up the PCR testing in very, simple ways, like multiplexing, where instead of a run of the PCR where you have the sample from one person, you can have a bunch of people whose samples are in there, and you code each of their samples. So I think scaling out testing to 7% is really going to turn out to be much, much easier than people think. But to just put a number on the table, let's suppose we spend $100 billion on scaling out testing, and how quickly, now people I'm talking to think we can do this within a month or 2 months to get to 7% of the population. And if you believe that number, then there's a strategy based on this. If you don't believe it, then we should talk about why you don't believe it. So Markus, you wanted, I think, to ask something, and there may be some other questions here.
Only one quick question which came up by Rula, associate professor of economics. He wanted to know what you're proposing. Does it only work for the US, or could a developing nation do the same thing? Is it also a feasible strategy for a developing like India?
Yeah. I think what the conversation will probably turn to now is the logistics and the feasibility of testing. I've been thinking specifically about the US. I think the thing about random testing is it's relatively easy to do. There are ways to be more efficient about finding people who are positive, like contact tracing. Contact tracing depends on culture and social institutions, human capital, technology. There might be differences between different countries in their ability to implement contact tracing. But let me be clear that contact tracing is only one of several different ways to target your testing and get a higher yield than when you're just testing at random. So on this backstop approach of just testing at random, I think any country can do this. And interestingly, the ways to scale up the testing that people have been showing me are actually ways that were developed to be done in developing countries where you don't have the ability to actually do PCR, this polymerase chain reaction. Turns out there are other ways. There's an isothermal method where you don't have to be alternating, the temperatures up and down the way you do with PCR. This method, this LAMP method, might actually be the fastest one to scale up in the United States, but it was designed to be easy to implement anywhere. So I think any country could implement random testing, and I think the resources to do it would be feasible for any country.
Thanks.
Now, do you want to, I bet there's probably some other questions right now.
There are other questions, but I guess would fit better later on because they're dealing with more broader issues.
Yeah, okay, well, so let me just elaborate on what I said a minute ago. So remember, the logical point here is that all you need to do to stop the spread of the virus is to isolate people who are infectious. And all that matters is how quickly you identify people who are infectious and isolate them. Random testing will get you all of those people. There's several ways to improve the yield for the amount of number of tests you run, improve the yield in terms of the number of positives you get. I think the most obvious one is to test by occupation. And I'm gonna expand on that in a minute, but just think of there's some occupations where the random person who works in that occupation is more likely to be positive. Another one is to test based on geography. If we have some baseline testing so we know what prevalence is in different areas, it would make sense to devote more of your testing resources to high prevalence areas. So if you've got a kind of a flying pool of equipment and resources that can move around, you very much want to concentrate your testing on high prevalence areas. Now, the third thing is you can try and use tracing people who've been in contact with somebody who proves to be positive as a way to also try and identify people who might be more likely to be infectious. But I think there's probably been an overemphasis on tracing, not enough consideration of other ways to improve the yield, and frankly, not enough analysis about whether tracing in a high prevalence environment actually improves the yield by very much. Because if you've got, like 20 million people, suppose we get to the point where there's 20 million people infected in the United States, suppose they've all got like 20 potential contacts, then you're dealing with 400 million people to go test in, you're back to random testing. So I think, and if you start asking people, how are you going to define contacts, you could easily end up with 20 contacts per person who's infectious. So I think we need to think carefully about whether testing is really viable or useful. Tracking, contact tracing, tracking is viable or useful. Yeah.
Let me just throw three questions in. So Rola Benabu asked, what's your take on wearing masks? There's a lot of studies and a lot of controversy on that. But then there's another question, you very much talk about infectious testing. What about testing for immunity? Is this something to look for? And right now we're in a lockdown phase, the transition phase from a lockdown to this testing. How does this transition phase, how would it work?
Great. Those are all good questions. So we have other ways to basically to slow down, to reduce R. One is barriers, of which a mask is an example. And then there's, like uniform isolation where we just isolate everybody because we don't know who's infectious. I think barriers are very important. I think masks are the obvious strategy for adoption right now. I've been asked by, for example, Governor Cuomo, what New York State should do. The very first thing we should be doing is requiring everybody who goes out in public in New York to wear a standard surgical mask. And the thing to understand about this is this doesn't protect you from inhaling droplets that have been, distributed by others, but it does tend to capture a large fraction of the droplets that you will exhale if you are infectious. So think of masks as protecting everybody else. And the only thing that's holding us back in the adoption of a rule that you have to wear a mask if you're going to go out in public is just a constraint on the supply of the masks. They don't want the public to take the masks that would otherwise go to the hospital workers. So masks, absolutely. And that's whether or not we can do the testing. On immunity, here's the thing. Again, it really helps to focus on the numbers. Right now, in most countries, the imperial estimates are there's 1 or 2% who've been infected. The goal in terms of saving lives is to keep that number very low, like maybe below 5% of the population who gets infected. So the number of workers, the percentage of workers, the workforce who might end up being immune is on the order of like a few percentage points. So from the point of view of like recovery of the economy, identifying the people who are probably immune because they've got the right profile on the antibody test, it's really almost just like rounding error compared to what we need to solve this problem. What the one thing antibodies do tell you is that those are people you don't ever have to PCR test anymore. So saves you a little bit there. On transition, here's how I would think about the transition. We have people who are at work right now. My daughter is a physician in a hospital in an ICU. She caught COVID. She's now recovering. First she couldn't even get tested after she got the symptoms. But the point is that she was probably infectious for a few days at work before she got a symptom, a cough, and then isolated herself. The first thing we should do if we have more testing capacity is test healthcare workers every single day, because they're so likely to be exposed, and it would be so costly if they infect each other as peers. So if you think about what would we do with more testing, the very first thing is test the high value workers who are already back at work. So we don't even need to talk about reentry, return, transition. Just test everybody who's a high value worker who's already at work. So all healthcare professionals, I think police officers, sanitation workers, you just kind of go down through the list, grocery store clerks. So if we had the testing capacity, very first thing we would do would be test and isolate some of them so that they don't infect each other as peers. The next thing is to think about in the hospital, it would also be good to just test every single patient who presents at a healthcare facility, find out right away if they're infectious, and then use extra care to protect all the healthcare professionals from this infectious patient. The default right now is to assume everybody could be infectious, but it would help to know with greater certainty about that. So these help us think about the ways that available testing could save lives right now better than we're saving with just social distance or with masks. But they also give us a kind of a clue about how we could start to put more of the weight on our strategy on testing and isolation and less on pure social distance. So once you've gotten to the point where you can test reasonably frequently, like maybe the sanitation workers, it's every week or every 2 weeks. They probably don't have to be tested every week. But once you've tested enough of the people who are already at work, then you just start to work down through lists of relatively important workers who maybe were not, got at work yet right now. Like, you got pharmacists, you got clerks who stock the shelves in a pharmacy. So, we can start to test and just follow the rule. If you get a negative test, you're good to go, but we're going to test you at random pretty frequently. If you get a positive test, you got to go into isolation for 14 days. And once we've kind of rolled this out, once we're using it for you know, a large fraction of the population, then we can start to gradually let various kinds of relatively important types of workers return to work, and you get a continuous transition to going back to the point where basically everybody who currently tests negative is free to go back to work, free to return to daily life. But we can do this without any additional deaths, and we could have a quicker recovery that could be worth many trillions of dollars.
I have more questions. If you want to keep on going with your slides, let me know. Otherwise,
no, it's a good time for questions.
So Hamming Fang from UPenn asks, what's about aggressive social tracing, contact tracing, and should we actually waive the health privacy protections in the HIPAA because we live in special circumstances?
Yep, I got it.
Then Gilles Duranton, also from UPenn at Wharton, asked, is random testing really random? And should we really care so much about it, or is it, you know, tracking through a personal app might be, you know, another way to go? And Diego Comín from Dartmouth asked, you know, enforcing the mandatory and discretionary confinement, how would you enforce it? How can you make sure that people really follow it? And of course, we have to make sure that, you know, they follow from your cell phone where you're going. Or can we go as far in a liberal society, in an open society?
Yeah. Okay. So let me give you very quick answers, and then we'll see if there's room for more discussion. On digital contact tracing, you know, apps, IT, phones, all of that stuff, my strong advice is do not even consider it. Just don't even talk about it. Because what's going to happen is the conversation about that is going to distract us and delay us. And I mean for months, like 6 months, we could be talking about privacy, you know, Big Brother, you know, and it just, we do not have the time to just waste on that issue. We don't need it. I wouldn't say we should even, I would say we don't even need to talk about it. I'm also assuming that at the prevalence that we're dealing with, even like 1 or 2% of the US population, it's not cost effective to use the traditional human methods to try and do contact tracing. And the challenge I want to put to anybody is if you want to talk about contact tracing as a way to increase the yield in identifying people who are positive, you've got to do the math and show us that for the resources we got, it actually increases the yield. So look, a lot of people don't agree with me on this, but I think, you know, the math here really has to rule. On random, I agree that random is just a baseline. What you want is to target your testing at people who are more likely to be infectious. And if you do that, you'll do better than random. And as I said, there's occupational targeting, there's geographic targeting, there could be other ways to target, but and you know, again, I would be very, very hesitant about using an app to do any of this, because every conversation I've been in that has even talked about apps has basically just gotten stuck in the mud. And so I think it's just, we don't have the time to spend on that discussion. Then on enforcing isolation.
It takes too long to develop the app, or it takes too, because the infection rate is so low in the population that it won't help, or?
Well, first, I mean, there's no app that I can look at right now to even judge what I think about it. So we're not there. We don't have an app. You know, if Cuomo's office asks me what they should do next week, I'm not going to tell him to go recommend vaporware. That's the first thing. But the second thing is, it's not the IT that's going to really hold us back here. It's going to be the social conversation and the distrust and the division that comes from talking about the use of an app. I mean, I could imagine there's something that people voluntarily opt into, but you know, just fine, do that if you want to try and set that up and people want to opt in. But I think any conversation about policy related to to digital tracking is going to cost us trillions in delay. And it's not even clear that it's beneficial on net. Now, on Diego's question about enforcement, look, it's kind of like you don't have to find every single person who's infectious to make sure this thing dies out. You don't have to make sure that every single person sent to isolation complies. You want to, adjust by math to allow for some non-compliance. But the first thing to do would be just to go with voluntary compliance. Tell people you're infected, give them some help about how to isolate themselves, warn them about the very serious risk of transmission to family members if they go home. So from the public side, we may actually want to even provide to them places they can go and be isolated where they're not at risk of infecting family members. But just start with voluntary compliance. And then if you're not achieving the goals that you need, start to look for just sort of gradual ways to improve on that. I mean, there is an idea that I think we could use, which is when, by the way, antibody testing would be helpful as a kind of a scanning surveillance mechanism. It's not going to free up many workers. If the government is encouraging tests, I would bundle together some kind of nucleic acid test and an antibody test because it provides useful information. But another thing you could do is when somebody gets those tests, and then if they happen to have the profile of somebody who's recovered, or if they test negative on the nucleic acid test, take a picture of them next to a sign that has the date and the fact that they've got a negative test result, and then print out a piece of paper that has that picture. Take the picture and also make it available on a website from the testing center. So if somebody wants to confirm it, let somebody show that piece of paper about a recent negative test if they encounter some resistance about, should we let you into the pharmacy? Should we let you into, the police headquarters? You could even have some rules that like restaurants can take reservations, but only from patrons who've had a negative PCR test within the last several days, like last 48 hours. So those create some incentives for people to want to go get tested. And I think they are kind of relatively less intrusive than something like, putting an ankle bracelet on people to monitor whether they stay home.
On this last point, do you think that that people don't internalize externalities, but I might be infectious, go to a restaurant, and I don't internalize that I might infect others? Or do you think the behavioral response is so much more pronounced that I'm so scared anyway to be infected by the others that people won't go to restaurants anyway? So let's suppose we open up restaurants and follow your policy. Will people go to restaurants, do you think?
Yep. Well, so there's a couple parts of that question. I mean, one is that there is a debate amongst the people who study these epidemics about whether an endogenous form of social distancing might actually get you most of the way towards getting R0 below 1. It could be without telling anybody to stay home. People just stop shaking hands. They stay a little bit farther away from each other. It's possible. Most of these models don't really know how much endogenous distancing is taking place, so they don't factor it in. I'm not at all confident that the endogenous results are enough to get R0 below 1. I mean, just look at Florida and the beaches and so forth. So, but just as an FYI, there is a academic intellectual debate about the extent of endogenous distancing. Now, in terms of something like restaurants, though, I think a restaurant might actually, on its own, even without a requirement from the government, say to its clients, we will only let people come into this restaurant and have a dinner if they show us a negative, nucleic test within the last, last 48 hours. That might help reassure people that it's okay to go back to restaurants. If the government got that word out, that might also be helpful. I think you could also encourage people in every encounter. It's like, the norms are changed now. The presumption is that when someone wants to get within 6 feet of you, they should start by showing you their piece of paper to show you they've got a negative test result in the last 48 hours. And if they don't, then you are fully within your rights to say, you know, you should not be out in public, you should not be talking to me. And you use kind of like social pressure and shame to signal if you don't have the negative recent test, you know, and, you know, after a while it could be within the last week or, you know, 2 weeks, but I think social pressure is a way to encourage enforcement here. But I think a kind of a government message that, you know, for example, we're only letting restaurants take reservations from people if they can show that they've had recent negative tests. That's part of how you build some confidence to get people to do things like go back to restaurants.
There's some other questions concerning if you were to minimize the hysteresis of the crisis. So would it be the same objective function? Do you know of any policy measures where you really are focused on minimizing the hysteresis of the crisis in order to, as you had in your earlier pictures, go back to as close as possible to the original trend? Would you do different things from just doing the current crisis management?
Yeah.
Well,
you know, to be honest, I think that would be something where like people who have more experience in like labor markets and some more kind of detailed micro interventions might be best able to help. I think the first thing is just to keep in mind that delay almost certainly makes hysteresis worse. So the urgent policy right now should be to move quickly. I also think that it was really unfortunate, a missed opportunity that we spent $2 trillion and didn't address the problem that we can't tell people to go back to work. It's like we're spending money to try and get the economy back to work, but we're simultaneously saying we don't want people to go back to work. I mean, this just seems like not the right kind of sequencing. So I would have spent $100 billion right out of the gate to get this testing capacity scaled out. Then started to look at things like, you know, stimulus type spending. I think there's a way to interpret the last bill as it wasn't really about stimulus. It was basically about bookkeeping entries to avoid kind of a system of cascading defaults. So, you know, you could argue that there was some value in like preventing just like cascading defaults and bankruptcies. But we should be clear that stimulus in the conventional sense is not going to work unless it's possible for people to go back to work and for people to go back to consuming. And 100 billion, I think, is probably, the people who understand the testing stuff right now think that that's like just like ludicrously too much money to get to, you know, 20 million tests a day. But you just think about the inefficiency and how pressing the issues are right now. You know, we'd be wise to spend 100 billion and be happy if you know, half of it was wasted. I can come back and talk about what I think are the real bottlenecks in that testing process right now. It's actually kind of a surprise. Swabs are actually a bigger deal than anything else at the moment. But you know, with some money, we could get, you know, swabs.
So there's some questions going on. So one is asked here from the Icelandic Fiscal Council asks, if you look across the countries, you know, can we learn from other countries? Is there, you know, some leading examples where I would say, oh, that should be copied in the United States or in other countries?
Well, Iceland is the country which is committed. They're going to test everybody. And I'm trying to find out from somebody in Iceland how quickly they think they can roll that out. But I don't have an answer on that yet. And I don't know how they're going to link testing to things like decisions about isolation.
And given the externalities of testing, and do you think the healthcare and the test cost and everything, the isolation cost and the treatment cost should be all provided for free? And it's a broader question.
Yeah.
By Lou.
I think we should just proceed adaptively here. And, you know, if we find that, say, you know, I mean, suppose the way to scale that testing was to expect everybody to pay $10 to get a test. You know, people might pay $10, it might work. If you're not getting enough people to do the testing to pay the $10, you know, maybe you make it free. You know, I think we should just be kind of adaptive as we approach that. My instinct, frankly, would be to start with free testing, but to bundle together the antibody test and the PCR test. And I also think the government will probably be important in creating the sites for these test centers. You could do some of this on like in shipping containers so you can move it around, or RVs, like blood banks do that. But I think you could also use physical sites like schools. New York City Health Department had a plan for emergency response during a, like some kind of biomedical emergency, where schools were the distributed physical locations where you could have people, interact with some kind of measures without having to go overload the healthcare system. So I think the government should be involved in probably facilitating the sites, and this is going to involve some kind of coordination between states if you want to have this mobile capacity to go test more intensively in those places where prevalence turns out to be higher.
So should we go on with questions, or if you want to cover like about?
Yeah, I really don't have, I think I've said basically what I wanted to say, except I could talk a little bit more about the technologies for testing and what, the likely path for progress is on testing, if people are interested. But if there are questions, I'm happy to take those first.
So there's some questions coming up where saying, oh, we have these draconian measures to lock down the country. Are there some models which give us some good indication, do you know macro models, what the total costs are and how much the long-run impact is of this long lockdown?
Yeah. I wouldn't trust a model on this, to be honest. I just don't think this is within our range of experience. What I'm looking at right now are indications about the unemployment rate, and then you use kind of some sense of the unemployment rate. You look at what was the historical experience in terms of changes in the unemployment rate relative to changes in GDP, and kind of go from unemployment to GDP losses. I think, just as we don't have enough real-time data about who's infected, we also don't have enough real-time data about what's going on in the economy. But the data that we're getting suggests that it's been a bigger shock, and certainly a much faster shock than anything we've ever experienced. The rough way to think about this is we've already had as big a hit, the hit to unemployment that we got over the whole course of the financial crisis, the 5 percentage point increase in unemployment at that time, that was really spread over 18 months. In 1 month, we've had as big an increase in unemployment as we had during the entire 18 months of the financial crisis. So this is hitting with exceptional speed. Same thing like auto sales. From March of 2007 to March 2008, auto sales fell by less than the fall in auto sales from last March to this March, and all of the fall in this year has come since February. So in 1 month, we've had a bigger fall in auto sales than we saw in a whole year during the financial crisis. So this is hitting with exceptional speed. I think it should make us expect, because of lags in the system, that there are going to be further losses that will come. And so I think the magnitude of this economic shock is actually going to be hard for people to believe, but we're easily talking about, tens of trillions of loss in output, and the kind of political and social disruption that the Great Depression caused. There are a lot of people who are ready to give up on capitalism, ready to give up on democracy. Some countries gave up on, democracy. Tried to switch to, more totalitarian, centrally planned kind of economic systems. So I think the potential risks we're running here are just bigger than anything we've ever encountered in my lifetime.
One final question, Kinga, I would like to know, you mentioned these bottlenecks earlier. If you could just, spend a few minutes, 1 minute or 2 minutes, and then we have to come to a close on these bottlenecks you mentioned earlier on the campus.
Sure. So there are 3 ways to get samples that you then test with these nucleic tests. Actually 4 ways. One is to use this swab that goes very high up in the nose. Um, and there's a very critical, there's only one firm that makes those swabs, and they haven't been able to ramp up production. But there are ways to do an intermediate distance up the nose, even one that's just right inside the nose. Part of what's happening is everybody's doing the swabs the way they've always done it, even though we don't know that that's really any better than testing and going partway up the nose or even in the right in the nostril area. There's also a distinction between the wet swabs, where it's got to be put back into some kind of liquid like culture medium, or just a dry swab, which might be just like taking a Q-tip and getting a sample that way. Somebody I talked to this morning told me that a dry swab from the mouth with just saliva, it could actually be has more virus than you get out of the nose. He says we've just been doing the nose because that's the thing that everybody did before. So there's really an enormous urgent need to do some testing, repeated testing of people, for example, who we know are positive, about various ways to collect these samples. If dry swabs like Q-tips would be enough to get a sample, and again, suppose the false negative rate goes up, from 30% to 40%, we got enough slack in this calculation that wouldn't matter if it really helps to scale out the testing. So, like if a dry swab or swabs from the mouth, if we could show quickly that those could work, as one guy says they actually work better than the nose, then we should be moving to that very quickly. The FDA had been a huge brake on regulatory approval of anything related to testing. That has apparently gotten better. But the FDA is still thinking about this as part of like clinical management. Like, are you going to make bad decisions for this patient based on a bad test result? And we can't allow like a false negative rate that leads to inadequate care. They got to stop talking about that and just realize that these PCR tests have nothing to do with clinical management of a person who's sick. They really, the last group, well, the very last group you don't want to test are people where the antibody test says they've recovered. Okay, but the next group that it's foolish to test are the people with symptoms, because the people with symptoms, you should just presume they're infectious and isolate them, protect healthcare workers, and then just monitor the course of their disease. If it turns out to be flu, fine. I mean, it was a good idea to isolate them, even if it was just the flu. So we got to get the FDA to stop thinking about this as a part of clinical management, and to start thinking about it as a part of basically just data collection. And they just need to just get the hell out of the way so we can do this. Now, let me be clear. On vaccines, we cannot do that. We need all of the rigor of the FDA approval process to make sure that vaccines are safe and effective. Because if we have a catastrophe with a vaccine that paralyzes, like 10,000 people or something, we're going to lose a social consensus. We're on the verge of losing it already. We're going to lose a social consensus around the idea that the government can require people to get vaccinated. And that would have its own enormous consequences in terms of loss of life. So you cannot kind of shortcut the safety or the efficacy process for vaccines. But on the testing stuff, they need to treat that, as just completely different. And if we can get to just Q-tips and dry swabs, it would radically speed up the process for getting samples. The other thing I alluded to is this idea of multiplexing samples, using this idea of you use a little bit of coding to put a little genetic code as a tag on each one of these samples. To do PCR, you got to tag anyway. So you just tag each person's sample in a distinctive way. Then you can multiplex large numbers of samples at the same time, and you can apparently scale up without a lot more physical infrastructure. You could scale up throughput apparently to an astonishing degree. So we just need to devote some resources getting people to experimenting, and then just test how well it's working.
Thanks a lot, Paul. It was a fascinating presentation. Let me just summarize the main message. I think the main message is we should do testing, 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 and it doesn't have to be perfect. We only have to get the R0 from above 1 to below 1. We don't have to get it to 0. And that's key, and that needs a change at the FDA and in the approach of doing things. And there are different tests, and we have to look at different tests, and we have to be very careful and use a careful approach for vaccination, because there might be then a backlash against vaccination, which might in the long run be very detrimental.
Yeah. So, if I could just, sorry, Marcus, if I could just add one kind of final comment. I think it's very important to recognize that this program is something that we could adopt it. I mean, imagine it turns out like HIV. We can't find a vaccine. We can't find a treatment that cures people of this disease. But, you know, if we're just testing, 20 million people a day, and then isolating anybody who gets, who tests positive, we can do that forever. And it's not very costly. If any new infections come in from outside the country, you catch them right away. So this is a policy which will restore confidence and certainty about what we're doing. If you've seen the simulations of these social distancing measures, it's kind of like lock everything down, let everything back up. The infection explodes again, lock it down. So you go back and forth. That kind of uncertainty about when we're going to go back into lockdown is just going to kill any prospect for recovery. So this is a policy, and any competitive policy needs to meet this criterion. This is a policy we can adopt, we can stick to as long as it takes, and literally for decades if we have to.
Thanks a lot. With this possible solution to the current crisis, I would like to thank Paul again. And yeah, we will put the video on the website, bcf.princeton.edu, if you want to see it, and also Paul's slide we will put there as well. And I hope that you can join us next week again, Monday and Friday during noontime, during the lunchtime, on Monday with Olivier, talking about the implications.
And by the way, for anybody who's interested, I'm on Twitter pretty actively about this right now, trying to tweet other sources that looked interesting and helpful. I'm also on my blog, so paulromer.net. So
yes, check out.
I'll be there if you want to learn more.
And all the information will be there as well. And I'm following Paul on Twitter. Of course, everybody interested in this topic should do the same. Thanks again, Paul.
Good.
Good
Okay.
to you, and I appreciate your time and your insights, and for the society to study this thing.
Yeah, well, thanks to everybody for listening. Yeah.
Cheers.